Hello guys, today we are going to discuss about a very important topic concerning with US English Staff 1, and that's going to be the hydrocephalus. Now let's dive deep into the topic. Now before we come to the topic that's the hydrocephalus, we need to understand about the CSF circulation which actually takes place. So let us proceed with it. First, where does CSF actually forms in? So CSF basically forms in by the choroid plexus, and within the choroid plexus we have a specific cells termed as ependymal cells, and these ependymal cells consist of a very specific transport known as a sodium potassium ATPase pump, which is often controlled by an enzyme known as carbonic anhydrase enzyme. And therefore we need to understand ki the CSF, it is basically produced by the choroid plexus, which are lying within the ventricles of the brain, and you have total of 4 ventricles in the brain, the 2 lateral ventricles, then comes the third ventricle, and then you have the fourth ventricle, right? So we have the 2 lateral ventricles placed in the placed in the 2 cerebral hemispheres. It consists of each of the lateral horns, anterior ventral horn, a posterior horn, and we need to know the how the lateral ventricle communicates with the third ventricle. So the lateral ventricle communicates with the third ventricle via a foramen of Monro, and through the foramen of Monro it enters into the third ventricle. Now you need to remember the third ventricle, the CSF will flow into the fourth ventricle. Now from third ventricle to the fourth ventricle, we have a passage which is known as cerebral aqueduct of Sylvius, and this cerebral aqueduct of Sylvius allows the movement of CSF from the third ventricle right to the fourth ventricle. Now, within the fourth ventricle, we have 3 doors in front of us, the 2 lateral one and 1 inferior one. But all the doors are leading you to the same way. Yes, it's the same way, that's the subarachnoid space. So the 2 lateral doors is L for L, that's its foramen of Leschke, and a midline door or an inferior door, that is foramen of Magendie. Now these doors, they are leading to the subarachnoid space. We know while we do a LP, that's the lumbar puncture, we obtain the CSF, and this is the same CSF from the subarachnoid space. Now within the subarachnoid space, you have a subarachnoid granulations, and these subarachnoid granulations perform the CSF absorption. Now from absorption, where does the CSF goes? It goes into your venous sinuses, that's the superior sagittal sinuses, and all along the venous circulation. This is how it circulates all along your brain. So taking a quick review about the CSF, cerebrospinal fluid, it's a fluid which actually supports the brain. It actually protects the brain as well from any kind of head trauma. And CSF is something which is being produced by the ependymal cells of the choroid plexus, and CSF circulated all along the ventricles, and it is being drained by the uh, subarachnoid granulations or the villi, right? Now let's proceed into the condition, that is the hydrocephalus. Now what does hydrocephalus means? Hydro and cephalus. Hydro means water or a fluid, and cephalus means a brain, means there is an accumulation of fluid within your brain or within your cranial cavity, right? Now let's see ki, why does the hydrocephalus arises. So hydrocephalus is basically a condition which occurs as a consequence of imbalance between your production and the drainage of the CSF. Now as far as hydrocephalus is concerned, you need to know that hydrocephalus consists of 4 variants, or basically it's divided into 2. Broadly it is divided into 2, one in a pediatric age group and second which occurs in adults. In pediatric we have 2 types of hydrocephalus, that's a non-communicating and a communicating hydrocephalus. Non-communicating is the obstructive variant of the hydrocephalus, and this it is related to certain obstructive causes. For example, you have the cerebral aqueduct of Sylvius stenosis, right? Aqueduct of Sylvius stenosis. Whenever there is a stenosis of cerebral aqueduct of Sylvius, it will result in the pressure being generated within the it will prevent the flow of the CSF from the third ventricle to the fourth ventricle, and thus will the CSF will keep accumulating within the third ventricle and the lateral ventricle till its dilatation. Therefore the lateral ventricles and the third ventricle is forced for dilatation, and they will eventually it will eventually result in it may result in the frontal bulging of the fontanelle, and it may even result in macrocephaly kind of things, right? So you need to know about this, and it may even lead to elevated intracranial pressure, which may even present with nausea, a projectile vomiting, headache, and kind of something kind of neurological deficits, and even may lead to seizures and may lead to death even, right, if not treated well. Now you need to know ki we have discussed about the non-obstructive causes of the hydrocephalus. Now let's discuss about the communicating causes of the hydrocephalus. Now what happens in communicating? uh, I need to review my notes, right? So the communicating causes are concerned, you need to know. In communicating, we know that the site of absorption of the CSF was the arachnoid villi. So in the communicating one, you have the impaired absorption of the CSF in the subarachnoid villi. Now it would result in the it would be due to the inflammation of the subarachnoid matter, that's meninges, involvement of the meningitis, right? And remember, in the meningitis of the communicating hydrocephalus, all the ventricles would be equally enlarged. Now what was occurring in the in a non-communicating or obstructive cause of the hydrocephalus? There was a dilatation and enlargement of the third ventricle along with the lateral ventricle, but the fourth ventricle was relatively spared. But what happens in the communicating one? The communicating one, which is mainly related to something kind of involvement of meninges, the impaired absorption of the CSF due to subarachnoid granuli or subarachnoid involvement, such as in the cases of meningitis, it may lead to the enlargement of all the ventricles of the brain, right? Now let's proceed to the another variant of the hydrocephalus which occurs in adults. In adults also we have the similar distribution of the hydrocephalus, that's the non-communicating and the communicating one, but they are well known as a normal pressure hydrocephalus, and we have a hydrocephalus XKVO. Now remember, the hydrocephalus XKVO, it's particularly specific for a particular disease of the brain, that's a neurodegenerative disorder related to age, that's Alzheimer's disease. And you need to remember, what happens is Alzheimer's disease is your excessive CSF accumulates in the region of the brain, and which results in the atrophy of the ventricles or the atrophy of the brain, and this atrophy of the brain is usually seen in Alzheimer's disease. And in the normal pressure hydrocephalus, you need to remember, it's similar to communicating hydrocephalus, and in a normal pressure hydrocephalus quite similar to communicating one. And communicating one, we know it's due to impaired absorption. So how the patient would be presenting with, see, simply remember, a normal pressure hydrocephalus will present with certain features involving impaired coordination, right? Impaired coordination of movements, and that's a literal term for ataxia. And apart from it, the patient may even present with dementia and urinary continence. So it's a triad. Normal pressure hydrocephalus, how do you remember it? You usually remember it by a triad, that's a dementia, ataxia, and a urinary incontinence. These two things you need to remember. Now we have something else also. We have two specific words, that's a Dendy Walker, and we have the Arnold-Chiari type 2 classification, right? So now Dendy Walker, you need to remember, there's a defect in the failure of foramen of Magendie and foramen of Luschke to open. So in Dendy Walker, remember, the it mainly occurs in children, and it is related to hydrocephalus in children. And how would the child present? The child would present with multiple attacks, multiple falling attacks, right? The child would have the history of he's falling very often. And why he's actually falling? Because he has an impaired control coordination of the movements, that's ataxia, that is the involvement of cerebellum, right? In Dendy Walker. And in Dendy Walker, remember, you have the D for Dendy, D for dilation of the fourth ventricle, and it is more likely to be associated with a disorder with a neural congenital neural anomaly, that's your spina bifida. Now as far as your Arnold-Chiari type 2 classification is being concerned, it's more likely to be due to a herniation of the cerebellum into the fourth ventricle or through the foramen magnum, such that the fourth ventricle is actually compressed, because the cerebellum itself falls or itself herniates into the your fourth ventricle. So remember, in Dendy Walker, Dendy Walker was characterized by the dilatation of the fourth ventricle. On the other hand, we have the Arnold-Chiari type 2 classification, which is characterized by the compression of the fourth ventricle due to the herniation of the cerebellum or the downward displacement of the cerebellum through the foramen magnum into the foramen magnum through the fourth ventricle. Now remember, your Arnold-Chiari type 2 classification is more likely associated with hydrocephalus and meningomyelocele. We already had studied about the meningomyelocele in our past videos, right? Now, I would also like to share you something very very specific known as congenital nerve anomalies. Now remember, as far as congenital neural anomalies are being concerned, you can divide it as a neural tube defect, which more commonly used, which most commonly comprises of the anencephaly and spina bifida. Now anencephaly, remember, neural tube defect, what have you, what problem are you encountering with? So remember, uh, in neural tube defect, you have simply the embryological or the developmental defect, right? It's a kind of developmental defect. And what kind of developmental defect do you need to encounter? Ki, you have the neural pore, and this neural pore, you need to remember ki neural pore normally closes at week 4 of the development, but if it fails to close, it's going to result in your neural tube defect. Now remember, neural tube defect can be further classified as anencephaly or spina bifida. The anencephaly, remember, your, it's like a test tube you are holding it with the upper mouth open, right? And when you invert this test tube, it's more likely to be spina bifida. This is how we remember. Now remember, in both this condition, why does the neural tube defect occur? So neural tube defect, it basically occurs due to the folic acid administration, due to the folate deficiency which occurs in mothers, right? Now you need to remember that there are two main conditions which occurs in amniotic fluid. Amniotic fluid, you would observe for very elevated alpha fetoproteins level and a high acetylcholinesterase enzyme level, which you will observe in the neural tube defects. And as far as spina bifida is concerned, we have three variants of spina bifida: the occulta or a hidden variant. Second is going to be your spina bifida meningocele and a meningomyelocele. Now remember, occulta, it's a hidden one, and it usually presents with a tuft of hairs which is present over the lumbar region, more likely to be a lumbar region, without the involvement of the spinal cord or the meninges or the dura, right? On the other hand, you have the myelocele and the meningomyelocele. Now what does myelocele means? Myelo means uh, sorry, we have meningocele and meningomyelocele. So meningocele itself means you have the meninges involvement here, and meningocele simply resemble ki, okay, you have a spina bifida conditions, you have a tuft of hairs, along with it you have the meninges entrapped on the lumbar aspect of the patient, right? Thirdly, you have the condition which is well known as spina bifida meningomyelocele. Meningo plus myelo, that's it's the involvement of meninges along with the spinal cord. Spinal cord means certain spinal roots will also be entrapped along with tuft of hairs present over the lumbar region, that's the vertebral column of the patient, right? So these things you need to remember. Now how does anencephaly would present? Anencephaly, you have a bacha who actually presents with a very bulging. Anencephaly means you have the absence of cranial cavity, you have the absence of head, and your eyes would be like bulging eyes. Yeah, the child would and it has a very less it has a very poor prognosis. The condition itself has a very poor prognosis, and almost it has a very high rate of mortality. The child dies within few days of birth, or it may even die as soon as uh, or it may die in utero even, right? So anencephaly, you need to remember कि anencephaly में bulging eyes वाला बच्चा होगा, absence of cranial cavity वाला बच्चा होगा. It would more oftenly be associated with with certain kind of other defects as well, right? And you need to remember कि folate metabolism is being compromised here, right? There's a folate deficiency which is encountered in the mother and which acts as a risk factor. Now what are the other risk factors which may result in neural tube defect? So you need to remember, most common congenital anomaly of the CNS is the neural tube defect, and whether it's autosomal dominant or recessive, remember it has a multifactorial inheritance. It is not being a certain condition related to autosomal dominance or a recessive pattern. What are the risk factors? So risk factors being includes remember, alcoholic mother exposed to radiations, and you can remember a diabetic mother, even a diabetic alcoholic mother who's exposed to radiations and who's taking something kind of anti-epileptic pills, kind of valproate or a carbamazepine, and she's also on a methotrexate therapy, right? And these two drugs, you are going to know it very thoroughly, that there are two main drugs which are affecting the folate metabolism, right? These two drugs are, first is impairing the folate absorption from the gut, and that's going to be your valproate, and second is methotrexate, which actually enables the dihydrofolate reductase enzyme, which is important for the folate production, right? So basically these are the two drugs which are going to affect the folate metabolism, and if the mother is on any of the medications, it is going to hamper, or it has a very high risk associated with a neural tube defect. So done and dusted, the neural tube defects are done and dusted. Now let's proceed to some other congenital neural anomaly which basically involves the posterior fossa. So you have three remaining: the posterior fossa one, you have the anterior fossa, and lastly you have the spinal cord, right? So what we have discussed, as far as we have discussed about the neural tube defect which involved the anencephaly and the spina bifida, and now we are proceeding towards the posterior fossa defects, then we will proceed to anterior fossa defects, and then the spinal cord. Now as far as posterior fossa is being concerned, it can be due to cerebral aqueduct of Sylvius involvement, Dendy Walker, or Arnold Chiari type 2 or type 3. And anterior fossa basically involve hollow prosencephaly. Now what does hollow prosencephaly means? Hollow prosencephaly is simply a condition which is mean where the two cerebral hemispheres are unable to detach from itself, right? So it's a condition where the two cerebral hemispheres are in a very close proximity, and they're being a single part, and it's more likely to be seen in the um, in a in the cyclops babies, or it's more commonly affecting a sonic hedgehog pathway, and the child would more likely to present with a fetal alcohol syndrome, and it's more likely associated with the trisomy 13, that's Tau syndrome, right? So this thing you need to remember about hollow prosencephaly, that's the anterior fossa involvement. Now let's talk about the posterior fossa. Posterior fossa, you have the three main things. You have the cerebral aqueduct stenosis. Second, you have the Arnold Chiari type 2, type 3 classification. Third, going to be the Dendy Walker. Dendy Walker, we talked about its opening defect in the foramen of Luschke and foramen of Magendie. On the other hand, we have the Arnold Chiari type 2 and type 3, which was actually concerned with the herniation of the brain tissue, herniation of the cerebellum into the cerebellum through the fourth ventricle into the foramen magnum, right? So these things you need to remember. And we have something known as spinal cord, that is syringomyelia. Now what does syringomyelia actually mean? Myelo means the word mylia itself means regarding something spoken about spinal cord, and syrinx means a cavity which is lined with fluid. So fluid filled cavity is there, a fluid filled cyst is present, not a cavity, let's say it's a cyst. So it's a fluid filled cyst which is present in the spinal cord, which is actually leading to certain symptoms. That's a syringomyelia. And remember, in syringomyelia, the most common pathway which is going to be affected is the lateral spinothalamic tract, because the pain and temperature on the ipsilateral aspect of the patient is going to be affected. How would the patient present with a pain and loss of temperature over the let's say right arm? So right, so it's a case of syringomyelia. Now let's talk about the posterior fossa one, that's our Arnold Chiari type 2 and type 3. Right. So we had already discussed about the Dendy Walker. What was Dendy Walker? There was a fluid filled cyst in the cerebellum vermis. Right. It was a fluid filled cyst in the cerebellum vermis, and the vermis controls the coordination of the proximal muscles. Right. So there is a difficulty in walking. So Dendy Walker, remember, in the Dendy Walker syndrome, the child won't be able to walk properly. He would have a history of falling more often. Right. Chiari type 1, type 2 are more likely to be a malposition of cerebellum. They are a malposition of cerebellum, simply a herniation of the cerebellum, downward displacement of the cerebellum. Remember, Chiari 1 is going to be less severe, Chiari 2 is going to be more severe. Chiari 1 is less severe, it has a syringomyelia as association. On the other hand, the Chiari 2, it's very bad. It has a very poor prognosis, and it is basically the herniation through the foramen magnum, which is more likely to result in the obstruction of the CSF flow, outflow tract, resulting in the condition of hydrocephalus and even the meningomyelocele being associated feature. Right. Now let's discuss about the features of the obstructive hydrocephalus. As far as obstructive hydrocephalus being concerned, you have two main things which you need to involve. We have the increase in head size, that's the macrocephaly, bulging fontanelle, seizures, increase in intracranial pressure, vomiting, poor feeding. These are going to be the associated features of the condition. Right. So this was all about for today. Thank you.